Hodge Centre has made a huge difference to what we've been able to do here in Cardiff. We've been able to develop young researchers with the specialist knowledge to bring together the immune system and the brain and look at really exciting new ways of understanding and treating mental health problems.
It's been a really enjoyable day, and it's really important to get people together from different disciplines. So we've had people working with animal models, people working in cellular models, people working with clinical populations. And it's only on days like this when you can really get everyone together and we can understand where we've got real commonality, but also where we need to think differently and learn from each other.
It's been really nice, especially after the last few years, to have everybody come together, and it's been some really fantastic talks from both in the department, early career researchers and other people from external sites to come in and talk about the importance of immunology and the really exciting research that's going on.
It's been an absolutely fantastic day. I mean, it's been such a pleasure to be invited here. The Hodge Centre, what an incredible centre of excellence for immunopsychiatry, and it's wonderful to hear that funding is going to continue. We need something like this that can help bring us together across the UK and internationally, and the number of trainees that are going to benefit from its existence is just wonderful.
The debate discussing targeting the neuroimmune system in therapeutics for schizophrenia was really interesting, because it sort of made you think about, actually, we're doing this research and considering, the basic research, but actually how can that be translated into an effective treatment, considering, how is it going to be delivered to patients and for how long?
It's been fantastic. There's been an amazing group of talks. It's been a wonderful day.
I've really enjoyed the day. In particular, I really enjoyed the lectures. It's been great to be brought up to date on all the advances in the field. It's been excellent to catch up with colleagues from Cardiff and also the wider research community. And in particular, I really enjoyed the debate.
Yeah, it's been wonderful because I've been given the opportunity to give a talk, and that is a great opportunity for early career researchers. And the day has been just brilliant, and I'm just looking forward to the public lecture.
It's so exciting to be able to develop the Hodge Centre from where it's been to the new vision. It's going to bring together different areas of activity that the Hodge Foundation has supported and enable us to really take a major step towards translating findings in basic science into impacts for patients. I'd like to start by thanking the Hodge Foundation for their generous support for our work. Our Hodge Centre has now been running amazingly for 5 years and has seen us being able to develop a fantastic cadre of young scientists taking forward work and the boundaries between immunology and neuroscience. And we've heard some of those scientists talking this afternoon, and it's been really inspirational and exciting to hear of the work that they've been doing and all that's been achieved. I can really think of nobody more suitable to give today's public lecture than Professor Rachel Upthegrove from Birmingham. She has a very impressive title of being both Professor of Psychiatry and Youth Mental Health at Birmingham, and she's also a consultant psychiatrist in the Birmingham Early Intervention Service for people at risk of psychosis. She has eclectic research interests, but she has been particularly interested in psychosis and in risk for major mental illness. And she leads a major MRC collaboration looking at immune processes in the brain, how they might affect risk for psychosis, and how that might identify for us new pathways to treatment. It's fantastic that amongst this busy schedule, Rachel's been able to find time to come and join us this evening, and I really appreciate it, and I'm really looking forward to your lecture. Thank you very much.
Thank you very much for the really kind introduction and for the invitation to come and not just to speak but to listen to some of the talks today. And I think it's just an amazing centre and it's an amazing group of preclinical and clinical researchers that have come together in the Hodge Centre. So I'm going to come away slightly jealous, if nothing else. I'm going to talk a little bit about the early stages of mental illness within the frame, of psychosis, and talk about the environment and the environment risk factors for psychosis and how that might allow us to understand a little bit more about the role the immune system might take within that. And if you were here for the debate, we've just had the potential for immune-targeted treatments. And I think we saw that the debate narrowly won. So maybe some of the things that I'll be talking about is how we might go about moving on to identify new treatments that target the immune system. The University of Birmingham is a beautiful campus. It's a lovely place to be and a lovely place to work. But Birmingham is a particular city. It's one of the youngest, or if not the youngest, cities in Europe. 1 in 5 people are born overseas, so it's what we call a super diverse city. And this slide is a little bit old now. It was 37% of the population live in poverty. That's now over 40% of the population living in poverty. So we have within the environment in Birmingham some of the things that are really, really relevant when we talk about risk for psychosis and how that might interact with some genetic predisposition. But this is a public lecture, and so I thought I'd start off by just, reminding us and talking through what we mean by psychosis. And you might notice that I talk about psychosis rather than schizophrenia through most of the talk, and that is for reason. Psychosis is the onset of what we call positive symptoms, so hallucinations, hearing voices when there's no one there, having unusual fixed beliefs that are held firmly without evidence, difficulties in organisation of thoughts, cognitive difficulties, and difficulties in motivation, energy, and self-care, negative symptoms as we might call them. For the majority, or for a certain percentage of people with psychosis, that does mean schizophrenia, and I haven't got time to go through the history of schizophrenia itself, but we know that schizophrenia in the core might affect up to 1% of the population, and as we've heard already today, that people with severe mental illness, including schizophrenia, have very poor life expectancy compared to the general population, and that is particularly around cardiovascular, metabolic disorders, and risk for suicide. And the impact, the personal and the societal impact of psychosis cannot be underestimated. But even aside from that, the cost to the UK economy is staggering. And I guess this figure is also probably now well out of date, because the 19 billion per annum in the UK has been around for the last 5 years at least. So this is significantly more now. I thought it might be useful just to start off by talking through what we know about the early stages of psychosis, when that develops, and how that is really, really relevant. So this is a schematic that anyone who's involved in sort of early intervention or schizophrenia research will be well aware of. But we have the gradual onset of positive symptoms occurring at a critical time of development, usually between the ages of 14 and 35. Somebody might experience a first episode psychosis, and this rarely happens just kind of de novo. There is often retrospectively a period of identifiable change, low-level positive symptoms, infrequent voices, infrequent beliefs that might not be held with certainty or might not be held for a significant length of time before the transition to first episode of psychosis. And this sort of idea of a staged model of schizophrenia has been behind the thinking of early intervention services for over 20 years. That if we can intervene early and give the best treatment, at this critical period, we might be able to alter the disease trajectory. We might be able to improve young people's functional recovery, their risk for relapse, and the impact of severe mental illness. But of course, the age of 40 to 35 is a really critical period of functional maturation. You're leaving home, you're going to university, you're getting your first jobs, you're finding your first relationships. It's also, as we've heard before, a critical period of brain maturation. So the idea that brains were just developed at birth is long since gone, and we know that there's a significant amount of growth, synaptic pruning, hardwiring that's set out during this period. And so Max Birchworth, who supervised my PhD back in the day, coined this phrase of this being a critical period, and if we could intervene here early, that might alter the illness impact. One of the things just just to talk about in terms of brain maturation, this is a paper from quite some time ago by Christos Pantelis's group with Stephen Wood, which showed that really that transition from what we might call an at-risk mental state to a first episode of psychosis is actually accompanied by significant changes in brain structure, and this occurs outside of the impact of antipsychotic or other medication. So during that early phase of illness, there is significant plasticity of the brain that is related to the transition to psychosis. So again, backing up the idea that this is a critical period. The other thing that we've learned over the years of working in early stages of psychosis is that it's also a very, very heterogeneous phase. And then when we talk about first episode psychosis, that is not the same as first episode schizophrenia. And people who present in my service or any early intervention service may leave with no diagnosis at all. And it may be that there is just one episode and it's resolved, non-treated. No other problems. A significant majority do leave our services with a diagnosis of schizophrenia. And in an inner city area like mine, about 70-80% of patients will actually meet diagnostic criteria for schizophrenia, but it's not all of them. And then we also have that first episode of bipolar disorder, with mania with psychotic symptoms, and the whole sort of bipolar disorder, schizophrenia, schizoaffective disorder, that Kraepelinian dichotomy, which again, perhaps we can talk about afterwards, but we don't have time to make here. But just to say, it's a very heterogeneous time. And that's relevant when we think about how we might target new treatments and when we might want to target new treatments. So coming back to Birmingham, perhaps, and just how this environment might impact the vulnerability. We know that we say that 1% of the population would develop psychosis, in lifetime. The number of people developing psychosis each year varies across the country considerably, and that's not just by population density. So in Birmingham, we see 300, plus new patients with psychosis every year, and that's an underestimation. In other parts of the country, that is much lower. Overall, we know that there are around 10,000 patients who develop psychosis each year, and this is. And I'm really sorry for this. I'm in Wales and I'm presenting a blank map, but this is data that's taken from that's modelled from James Kirkbride's NCAP and Synaptic work, and we have developing early intervention services in Wales, particularly at Cardiff in the Iron Bevan, which very grateful to be collaborating with them. But what we can see from this is areas of high population density, high deprivation, a young age, an ethnic minority. That ethnic diversity really impacts on the rates of psychosis. So this is how the environment might be affecting that genetic perhaps risk. The other really important thing to say is that despite our best efforts in early intervention, and we've been delivering services in Birmingham since 1996, and now have national coverage, including some services in Wales, as I said, despite our best biopsychosocial treatments with, cognitive therapy, family interventions, clozapine indicated support, and employment and education, despite really intensive gold standard early intervention care, I don't think anyone would say that this was good enough. So a symptomatic remission occurring in less than 50%, functional remission less than 35%, and again, those physical healthcare outcomes haven't really improved at all. So better treatments are needed, and particularly new treatments, and that can be anything from. Shout out to the study here that Cardiff and Vale and Iron Bevan and James and Jeremy are helping us with here, which we're looking at repurposing antidepressants, but we also need to look at other and new treatments potentially targeting the immune system. In our group, we're interested in interleukin-6, this low molecular weight protein, which is present in the circulation, but also can cross the blood-brain barrier and has a number of different effects. So IL-6 has sometimes been called the bandmaster of the innate immune system because it has both upstream and downstream effects, and it's a very important, protein from our understanding, and hopefully not just because that's the one that's been measured over the last year. So we've got this evidence because you can pulled evidence together on what's been measured. So this is a paper from the Golan produced quite some years ago now, which showed the first time that there was a longitudinal relationship. So children that had elevated IL-6, at the age 9 were more likely to develop psychosis. So that longitudinal relationship, even when controlling for a number of different sort of environmental factors. And we were able to show in the systematic review and meta-analysis that IL-6 was increased in psychosis, people who developed psychosis prior to medication. So pulling together all of the data from medication-naive subjects. So there's a hint that this might be relevant both for risk and during the psychosis onset. But I suppose the idea is that how could IL-6 be relevant to brain? And this is something that we've heard today in numerous different ways of people trying to understand this in the human context. Just a couple of points that we've been writing about. Of course, IL-6 can cross the blood-brain barrier. This idea that the brain is immune protective, I don't think anyone here would ascribe to. Its effects aren't just in terms of activating microglia from resting state to activated microglia. There's other things that could be happening, including sort of the generation of reactive oxygen species and increased oxidative stress, which may have subsequent effects on brain maturation, and also sort of secondary messenger effects which impact on the very sort of dopaminergic or glutamatergic excitation inhibition that's coming out through some of the more recent GWAS data. So, as I said before, IL-6 is a target of interest, not just because we can measure it and not just because it might be something that activates microglia. All of this is leading up to what we're now literally very excited to say, that we've had the green light, and we've recruited our first healthy control this week. And I was with the clinical team this morning launching the study, so we'll be recruiting patients to this. From now onwards is our targeted experimental medicine study in patients with first episode psychosis. So having some evidence, I think we've validated IL-6 as a potential target. What can we really understand about the mechanisms through that? So we are recruiting patients in Birmingham, Bristol and Cambridge. So myself and Golan leading this consortium, identifying immune active psychosis, and I feel quite embarrassed if there's an immunologist in the room saying immune active with a IL-6 level of 0.7. But actually, I think it's really, really interesting. If you trawl the literature, there's very little evidence of how you might define immune active versus non-active patients with schizophrenia, and we've done quite a lot of interrogating the literature and modelling this within our existing data sets and within the Pronia consortium to try and find a way of just saying we're tickling the IL-6, an IL-6 system. So we're going to be recruiting patients, with that profile and a degree of anhedonia into the experimental medicine study, and having a one-off infusion of teclistamab, and then measuring a number of different mechanistic outcomes. Our clinical outcome is anhedonia with cognition and positive symptoms, but this is primarily an experimental medicine study where we're looking at the mechanisms to see whether we can really understand the potential mechanisms underlying this in patients with schizophrenia. IL-6 being teclistamab being something that will actually sort of turn off your IL-6 signaling, so we can then see what happens before and after. In summary, early stages of mental health disorders are really, really heterogeneous, and there's a complex relationship between our genetic risk and environment. The environment is very, very important, and the immune system might be ways of understanding the impact of deprivation, minority status, urbanicity, childhood trauma, and the subsequent presentation of major mental illnesses, including psychosis, that we think that there's a potential pathway for immune dysfunction, and anti-inflammatory agents or new treatments may be helpful, but only if we understand how to better target them. And, you know, data science may help refine the approach, but what we really need is more mechanistic studies in patients to be really clear about what are and aren't potential targets. And I think just as a shout out to the really brilliant work that's being done here at the Institute, this kind of idea of, you know, forward translation from animal models into humans, but also back translation from human, you know, experimental medicine studies back into basic science is so crucial. And what I haven't talked about, and perhaps can overdrinks after, is how we're taking some of this back into mouse models of maternal immune activation to really trying to understand the results we're getting here, you know, to better inform, you know, hopefully some other animal models of immune activation in psychosis. So this backwards and forwards translation and interdisciplinarity is really crucial. That's why it's so lovely to come and listen to everything that's been happening here. So thank you.